Hello. Give me one moment. Hello, Dr. Court. One of our doctors is calling, and we're going to have to get him on. Just give me one moment here. You need the, yeah. Okay, we will in a moment, Dr. Court. Thank you. Dr. Court needs the email. Hello, everyone. Sorry about that. We're just taking care of some technical so that we can get the show going, the webinar going. Welcome. It's summertime, and I understand that some of our doctors are out enjoying themselves. So we may have a slim crew today, but we'll be here and we're going to talk about kidney failure. And this is part 2. We had such a large response last time that we talked about this topic that we felt we needed to do it one more time to cover it completely, because it's something that is, boy, it's a part of people of African descent. It's a part of our one of the illnesses that affect us dramatically, I should say, because of hypertension, because of diabetes, and those things are definitely in our community and are a part of the illnesses that we suffer with. Kidney failure is secondary to that. And well, those are some of the things that kidney failure is secondary to. And I think it's so important that we cover this topic broadly, such that we're educated about it as far as the community is concerned. We're a group of Black physicians, and we're here for two main reasons. Number one is to improve the knowledge of healthcare of people of African descent. Number two is to let young Black brothers, I should say, know that they can be physicians. It's possible. And we encourage them, if they have an interest in science, to please think about becoming a doctor. Understand that our webinar is every second Saturday at 1 o'clock, all righty? And you can join the webinar very easily. Just come on to OBHealthy's website, that's OBHealthy. And all you need to do is hit the physician tab on the top of the web page and come in and join our webinar. Once you join the webinar, please do not hesitate to type your question in. It's so important that if you have a question, type it in, because we try so hard to answer each and every question. All righty. Remember that you can see our past webinars on the OBHealthy website. All you have to do is hit our YouTube sign, and all of our past webinars will come up. It's important that you take a look at them. Education's just an enormous amount of education, medical education for you on those. All righty. I'd like to thank OBHealthy for allowing us to use their platform so we can bring this webinar to you, number one. And number two, the most important thing that I can say today is please do not change any aspect of your medical care until you consult your physician. Only your doctor truly can take care of you from a medical standpoint. All right. So we have a number of things that we can talk about today, but what I'd like to start with, and we will eventually get to the kidney because we're waiting for our Dr. Simon our nephrologist to sign on. But before that, I would like to talk about asthma, and because asthma it's something that's very common across the board. No matter what race you are, asthma it's so common. And understand, asthma is something that it can be, you don't have to have a specific, per se, problem initially with asthma for asthma to develop throughout your lifetime. Let me just back up on that for a minute. What is asthma? Asthma is a state where your airways actually go into spasm, and in that spasm, it decreases the air that you can get into your lungs. So you actually have that wheeze because the air is trying to go through a tube that is narrow at that particular point. You become short of breath, your heart rate increases, you have a lot of cough, congestion, your blood pressure goes up. All of these things occur during an asthma attack. Let me explain the airway again, just to just to give you a better understanding. The airway has many types of cells in it. It has smooth muscle cells and those are the cells that actually, smooth muscle cells are the ones that contract and make the airway smaller during an asthma attack. Understand? It also has cells that are called mucus producing cells because our airways always produce mucus. We always have our airways. You never want your airway to be dry. It's always mucus there. It's always moisture, and it allows our airway to function appropriately. But during an asthma attack, that mucus increases dramatically, and that mucus gets stuck in the small airways, which makes it even harder to breathe and harder to get air through the airways to the lung tissues. Okay. Understand that asthma usually occurs as a child, and there is, most of the time, I should say, asthma, you can relate asthma to a family history, meaning that mom or dad or a cousin or grandma may have that history as well. So, and thinking about it, you should always try to understand your family history, because we are who our parents or our grandparents were. Genetically, we are those people, and the illnesses that they had or have, there's a good chance that sometime during our lifetime, we may have those illnesses as well, just as a side. So the thing of it is that asthma is usually a bimodal disease. And what do I mean by that, bimodal? Asthma usually will affect you sometime early in life. So your children, if you had asthma, you will find that your children may have the wheezing or may have, the shortness of breath and need the particular medications that will dilate the airways. They have that problem. Usually somewhere when you're about a teenager or in your early 20s, for some reason, a lot of asthmatics that particular disease, it kind of decreases as far as the symptoms are concerned. You don't have those attacks as bad as you used to when you were younger. And then for some reason, some unknown reason, later in life, maybe about 35, 40, those symptoms start coming back again. All righty. So it's called a bimodal disease. Now that is not absolute. Understand that there are people that have asthma in an early stage of life that do not, and they grow out, they said, I grew out of my asthma, and later in life, they don't have it. Whereas others may not have it in that early stage and may develop it in 35 or 40 and say, boy, I never had asthma before. Why all of a sudden am I having this shortness of breath? So, medicine is, or I should, our bodies and disease entities are not an exact science. All right, we're all different, and each of us experience these problems differently. Okay, how do we evaluate for asthma? That's a good question as well. One of the things that's so important, it's called a pulmonary function test. All righty. And what is a pulmonary function test? It's the ability for us to understand the function of our airways. And so how well or how easy does the air travel through the airways itself before it gets to the lung tissues? How easily does, or should I say, do the lung tissues stretch to accept the volume of air that each of us should be able to accept? And that volume is determined by height, weight, sex, age, and race. And the computer will manipulate some formula that I can't call off the top of my head right now, but it will tell you exactly how much volume you'll be able to accept in a maximum inhale, and that tells us how easily your lungs stretch to accept that volume. All righty. The third thing that tells us is once that air is in your airways and it goes into the lung tissue, if my hand was if the lungs were on this side and my bloodstream is on this side, well, guess what? The oxygen in that air has to diffuse or go across that membrane and get into the bloodstream. Well, if for some reason that membrane has been damaged, like for emphysema or for bronchitis, chronic bronchitis, if there's a damage in that membrane where that oxygen cannot get across effectively, well, guess what? You're short of breath. And those are some of the things, because with asthma, remember I was telling you that there's a lot of fluid that's developed, the lungs get congested, all of that. That membrane, sometimes the oxygen has a hard time getting across. And there are other reasons that oxygen could have a hard time. There could be fibrosis for whatever reason in that membrane. There could be fluid like congestive heart failure that Dr. Atherley takes care of in that membrane that inhibits that oxygen from going across. So that's another thing that pulmonary function tests allow us to assess. The second thing that I need and to actually truly understand what the lung is doing is a chest x-ray. Chest x-ray gives me structure. Pulmonary function test lets me know the function of each aspect of the lung, but the chest x-ray allows me to know what the structure looks like. Is there congestion in the lung? Is there a growth in the lung, or a tumor in the lung, or a cancer in the lung? Is there infection in the lung where there may be pneumonia, or is it mostly bronchitis, or exactly what's going on in the lung? So asthma, true asthma, the lung chest x-ray should be normal, because asthma is not an infection. It's what stimulates the asthma can be an allergic reaction, or you can be walking by a barbecue pit, or whatever that would irritate your airways, and the bronchospasm happens. Bronchitis, the difference between bronchitis and one of the differences between bronchitis and asthma is that bronchitis is an infection. So you have to add antibiotics to a bronchitic who has an acute bronchitis, but there is no antibiotics needed for an asthma person. We give the appropriate medications to allow those smooth muscles to relax and open up, and give medications that will decrease the swelling and the mucus production in those airways, and the patients do much, much better without antibiotics. That's a quick cover as far as asthma is concerned. Now I know I got some hands up there.
We have a bunch of questions for you.
I'm going to tackle you first, and then Kevin, you second.
A bunch of questions for you.
Yes.
I'll let Dr. Atherley go first.
All righty.
I want to say that you covered it so well, but from the patient perspective, the essential aspect of asthma that they recognize is shortness of breath. And we're very well aware that as physicians, there are many causes of shortness of breath. What clue might the patient have before we even get the opportunity to perform chest x-rays or perform pulmonary function tests? A patient who may be in a gathering and suddenly feels short of breath. How can we guide them? I can say that from my viewpoint, shortness of breath is also a very major or important symptom in heart failure. And maybe at some point I can define what heart failure is for you, for the audience as a whole. But the shortness of breath may be so frequently seen in many conditions that I'm sure we can all give some idea of shortness of breath from our own perspective. Let me say, if we are thinking about shortness of breath from the point of view of heart failure, whether it's a long-standing chronic heart failure or an acute or new onset heart failure, the shortness of breath is, of course, a very important one of the findings. To understand heart failure, however, if we claim that the heart is failing, but what does the heart do and how does it function when it is not failing? So I may need to mention a little bit of the anatomy and the function of the heart in a normal sense before we go on to failure. And as we all know, the heart is the most powerful, perhaps the most important pump that we have in the body. It works unceasingly, of course. And part of the concept of failure of the heart may then relate to the heart's inability to pump blood forward to all of the rest of tissues as needed. But we also know of the so-called backward failure, where it fails, whereby its failure, it not only fails to execute the forward motion, but it allows blood to back up in the tissues and areas where the blood would normally have traversed before reaching the heart. Heart sends the blood out, oxygenated blood, good clean blood, it goes out carrying oxygen and nutrients to the various tissues. It is then returned via veins to the right side of the heart, purified in the pulmonary or lung situation, and then reaches the left side to be pumped up again. So if the heart fails, and let's take, for example, the symptoms associated with the backward failure, where the blood that comes back to the heart reaches the lungs, but doesn't get pumped out effectively to the rest of the body. This may occur because pressures develop in the powerful pumping chambers of the heart, and we have what's so-called diastolic failure. That is failure of the heart muscle to relax and allow that blood to fill it properly before it goes out. So the heart muscle becomes stiffened for whatever reason, does not relax adequately, and blood backs up. Well, where's it back up? It can back up into the lungs. If it does, then shortness of breath in a variety of manners may be observed. Of course, we can also have the backing up manifested by edema elsewhere. So patients may present with swelling of the ankles, the lower limbs, for example, because the fluid that accumulated there oozes out of the veins, the bloodstream, and does not properly get restored back into the active bloodstream to the left side of the heart to be pumped further. So backward failure, or what we now call heart failure with even preserved strength of the heart, it may be failing because it is not pumping, not allowing blood to come and fill it adequately. Shortness of breath is one of those parameters. Okay. How does that shortness of breath differ from the shortness of breath with asthma? Well, sometimes the patients with asthma may have audible wheezing, which again, Omar can tell us about, and that is not usually seen in the typical congestive heart failure. But the shortness of breath may occur gradually over a period of time. Again, we will talk about the exception that we sometimes come to call acute pulmonary edema. But short of that, in the gradual buildup of congestive heart failure, the patient may have other symptoms, may have tiredness, usual fatigue, weakness, etc. But shortness of breath may be an important aspect. And the shortness of breath may not be manifest when sitting quietly, but the patient decides to walk up 2 flights of stairs and then finds that he's unable to walk up 2 flights of stairs where they could before, then unable to walk 1 flight of stairs. That kind of shortness of breath, dyspnea on exertion, we may consider it. Then the question of the shortness of breath accumulating based on the patient's position. So a patient may lay quietly in bed and usually using only 1 pillow, but then may find themselves having what we call orthopnea, or the need to have more pillows to prop up. That diminishes the blood flow that returns to the heart in a failing heart, and so diminishes the potential for that blood flow to back up in the lungs. So a patient may find themselves suddenly requiring more pillows at night in order to breathe adequately and to sleep through the night. Even worse, maybe what's called paroxysmal nocturnal dyspnea. What that really means, that patients may have abrupt shortness of breath, which wakes them up from sleep, but they have to actually change the position, get out of bed, sit on the side of the bed, or stand up to allow blood to pool further in the lower limbs, the lower extremities, less blood returning to that failing heart to overload the heart, if you will. So that's another form of the shortness of breath that a patient may experience with heart failure. There are many other manifestations that we can consider, but I want to stick just to the shortness of breath and try to compare it to the shortness of breath which may occur suddenly in the patient who's having an acute asthmatic attack. So Omar, if you want to comment a little further on the abruptness of the episodes, gradual with the heart, but maybe more abruptly with an acute asthmatic attack.
Excellent, excellent. Dr. Clark.
I was just gonna go back to the actual diagnosis. And as a kid, I was told I had asthma. I was treated for asthma. And then gradually as an adult, you mentioned this before, you grow out of it, which is something I never really understood. And when you make the diagnosis, is it a blood test? Is it a combination of the pulmonary function test? Is it the presenting symptoms? And what other disease processes possibly overlap with asthma that you could be treating as asthma, that may be something else?
Alrighty, yeah. The thing of it is that, and I find that, and just to start this off, because it's an excellent question. I find that a lot of times patients will come to me with the diagnosis of asthma that I don't feel they truly have asthma. And unfortunately, once you give that diagnosis of asthma and you put that on a person's chart, if they go to get insurance or anything like that, that diagnosis makes it more difficult for them to get insurance, you know, whatever type of insurance, health insurance, life insurance stuff, just because of that diagnosis. I find a lot of times there is hyperreactive airway syndrome. What that means is that you may have airways that have been, you know, because you have esophageal reflux or GERD, and your airways are always being irritated by a little acid, so that you have more responsive airways to any insult than normal. But you don't have asthma. Now, just stepping back, how do we make the diagnosis? Number one, we take a good history. As I stated, genetically, we are our parents. And if there's a chance that your mom or dad or grandma truly had asthma, then there's a good chance that the kids may have asthma as well. The other thing is that there are things like nasal polyps that they're, you know, and seasonal allergies and things like this, that there's a triad that we call, that we can kind of look at and say, you know, there's a good chance that this particular person may have asthma. As well as the pulmonary function test. The pulmonary function test, there's part of that test that I did not describe, which is called the bronchodilator effect. And what that means is that I'm going to give this person a test, and let me just step back. Let me describe what we do, and then maybe you'll understand what I mean. In that test, there is one part of it called the FEV1, and we should be able to exhale on a forceful exhale 75% of our lung volume in 1 second if our airways are fully dilated. Okay. Now, if the amount you exhale decreases and you can't get it all out in 1 second, the flow volume loop will be a change in the loop, how that flow came out, and we will know that there's an obstructive component, meaning that something's obstructing the air from coming from our lungs and through our airways and out of our lungs, out through our mouth. Well, there's a second part of that where after we do that test, we give the patient what we call a bronchodilator. And a lot of patients know these as, you know, a rescue inhaler or albuterol. And what does albuterol do? Albuterol relaxes those smooth muscles around the airways and allow that airway to open up. Now, once we give that albuterol and we repeat that FEV1, that forceful exhale, if there's an increase of greater than 12% of the lung volume coming out in that 1 second, then that's positive for a responsive airway to a bronchodilator. There are other diseases that may cause the airway to be narrow and to have, how should I say, difficulty getting rid of that air, but they won't have a responsive airway, you know, that will react to bronchodilator greater than 12%. It may be 5%, it may be 10%, whatever, but it has to be greater than 12%. And what that allows us to know is that this is most likely asthma. Bronchitis is just completely different. Bronchitis is an infection. A lot of times bronchitis causes, because it's an infection, it causes scarring in that lung tissue over time. Things like esophageal reflux causes scarring in the tissues and permanent changes in the airway. These permanent changes do not respond to the degree that asthma will respond to in the airway. Yes.
And just quickly before Dr. Salam, COPD, since you mentioned the test and the responsiveness, how would you, how is COPD different in that test?
Okay, number one, it would not have the bronchodilator response. Okay, number two, it all depends on what type of COPD. You're really opening up a big bag of worms here. Okay, real fast. COPD is an umbrella term. It encompasses emphysema and bronchitis. Emphysema is about 20% of COPD. Bronchitis is probably about 70%, and then we have some others. Understand that out in the community and lay terms, anyone that says they have emphysema, you get worried because you're thinking oxygen and really bad lungs. Well, guess what? Bronchitis is even just as bad or worse than emphysema. So what is emphysema? Real quick. Emphysema, our lungs are made of something called alveoli. And alveoli are little round sacs, billions of little round sacs that when we inhale, they stretch out and accept the oxygen. Emphysema, which happens because of smoking cigarettes, is that those little air sacs are very fragile and they fracture. And if I fracture a lot of those little air sacs, then I don't have little air sacs anymore. Now I have a larger air sac because all of the little ones fractured. I have a larger air sac that's irregular, and the blood vessels as well as the airways, small airways that travel through the lung now don't travel smooth and easy. They travel crooked because all the contours changed. So with emphysema, what you have is you have a patient that always has a large lung, because what happens, I'm gonna have to take give me one moment. Dr. Simon? Alrighty, I think our Dr. Simon is having a little problem coming in. Hold on just for a second. Can we, do you have his number? Okay, we'll take care of that. So once they're fractured, then all you need is like a traffic jam, a bottleneck, because the airways are going like this coming, they're not smooth and going through. You need one bottleneck and you can't get the air out. So an emphysematous person always have a half full lung. They never are able to get that full breath in because they never let the exhale out to allow the volume to come out so that they could get a larger volume back in. That's emphysema. Bronchitis basically is an irritation that there is scarring on the airway so that the airway does not stretch. So the volume that you take in is less, because now if the lung is like a balloon, it has elastic tissue. And when it stretches, you inhale, it stretches to accept the volume. Well, if there's scarring on the lung tissue, not the airways, the lung tissue, that lung tissue can't stretch because scars don't stretch. They don't have the elastic tissue. So now your volume is low. So you're short of breath because you can't take a deep volume. So there's two different concepts. And I just wanted to explain that and not let us go past emphysema and bronchitis. And at the end of the day, they both lead to chronic lung disease, chronic shortness of breath, and both could lead to oxygen dependent because we don't get enough oxygen to our bodies in our bloodstream. Okay, we got hands up. I opened up the Pandora's box here. Let's keep going. Dr. Salam and then Dr. Court.
So while I have the floor, why don't I introduce myself? I'm Dr. Kareem Latif
Hold
Salam.
up, Dr. Salam. Hold up, Dr. Salam. That was my fault. Let's all introduce ourselves and then you'll start. Dr. Salam, go ahead.
So I'm Dr. Kareem Salam, board certified adult and child and adolescent psychiatrist. And I practice in the city of brotherly love and sisterly affection, more commonly known as Philadelphia. And it's a delight to be here this afternoon.
All right. Dr. Court, please.
Dr. James Court, my specialty is internal medicine. I practice in East Orange.
All right. Dr. Atherley.
My name is Trevor Atherley. I'm an interventional cardiologist. I practice predominantly at Newark Beth Israel Medical Center. Glad to be here.
And Dr. Kevin Clark.
Good afternoon, Dr. Kevin Clark. I'm a surgical oncologist. I practice at Newark Beth Israel Medical Center.
All right, excellent. Dr. Salam, you know, Dr. Salam, I want to preface this because we're talking about something that's a chronic disease. All righty. And just like kidney failure and asthma and diabetes and all of those are chronic diseases. Now, I know you have your question, but once you ask your question and we get through that, I want you to just give me an understanding from your perspective as a psychiatrist, what chronic disease, how do we handle chronic disease in our community such that, you know what I mean, from your perspective, how do you handle that? Because it must be dramatic for a patient to have something that they know their lifestyle has changed dramatically and they can't get it back. Talk to me.
Sure. So since I've been standing in line for a while, I'd like to ask my question. And my question is directed towards Dr. Bay and Dr. Atherley. Now, in this part of the country and wide swaths of the country this summer, we've been exposed to this toxic air. So I want to think in terms of environmental risk factors that could exacerbate or activate pulmonary disease.
Mhm.
So, and I want you to speak to why asthma in particular is clustered among communities of color. So that's one.
Mhm.
So the environmental impacts of asthma and why asthma cases are clustered in communities of color. And two, it's never been completely clear to me why folks who have heart disease, separate and apart from lung disease, are at risk when exposed to this bad air. So whether it be some type of air pollution or what we've experienced with these Canadian wildfires, could you explain why that would be a risk for folks who have cardiac disease?
Mm-hmm. Let me start off, Dr. Atherley, and then I'll let you chime in on that as well. Let's start off with the atmosphere that we've all been having to deal with from the fires coming over from Canada and all of the stuff in the air. It's an irritant. And when you have any airway disease, say asthma, or if you have bronchitis or you have emphysema, understand that your lungs are the amount of function that you have in your lungs are decreased. And any irritation, any bronchospasm, any increased mucus, anything that occurs, you will feel it symptomatically because our body recognizes automatically when we decrease our oxygen. Automatically, we don't have the ability to store oxygen in our bodies. So our body, once we take a breath in, that oxygen has to cross the membrane and deliver itself to our cells like that, or we're in trouble. And our brain recognizes that any trouble with that diffusion, I should say, instantly. So any irritation of the airways, of bronchospasm, anything like that, we recognize it automatically. There's no, to me, as a pulmonologist, there's no other feeling that makes you as anxious as feeling that you just don't have enough breath, or that mucus is producing, or that, that irritation is increasing, there's more mucus production, there's more bronchospasm. Now, you also stated that why do you feel that asthma is more of a problem in the inner city where we live? Number one, inner city. We're talking about where there are more cars being driven down the street. We're talking about where there are more rodents more likely to be in the homes, roaches to be in the homes. All of those can be irritants. We're talking about areas where there may be, because of the cars and all of that, there may be more dust in the apartments, and it's more of an apartment where the windows, you may not get more fresh air, and there are so many dynamics that can cause irritation of an airway that is already primed to be irritated. So I think there are a lot of, say, things that we come in contact with each day that can irritate our airways. And that's one of the reasons why I feel that it may be more prevalent in our communities.
Could I quickly I want to make a quick comment since we're talking about irritants in urban communities.
Mhm.
What I'm about to mention is one that is grossly ignored, but it has substantial cardiovascular side effects, not necessarily pulmonary, but cardiovascular. And Dr. Atherley will be very interested in what I'm about to say. I just read a compelling article about the impact that noise pollution has on cardiovascular mortality, and it works with ruthless efficiency. It can increase blood pressure. So if you live, let's say, near the BQE, the Brooklyn Queens Expressway, you live near an airport, or you live near train tracks, that constant noise activates your hypothalamic pituitary adrenal axis. Your blood pressure goes up, which makes your heart work harder to pump against that high pressure head. And over time, it's constant. You don't get a break, right? These trains are running, the cars are driving, the planes are flying. You don't get a break. These loud noises could increase cardiovascular mortality. And it works really, really quickly. It was in Science Times and the New York Times. I want to say within the last 2 weeks, it was a very compelling article. Speaking of environmental irritants.
Very interesting point you raised, Dr. Salam. I can address them peripherally, I suppose. In the instances that you're asking, the heart is secondarily involved. It is not as though there's a primary noxious event on the heart, but certainly in the situation where noise can affect blood pressure, that blood pressure may increase the work that the heart does. The heart work is related to both the upper, that's the systolic, and the diastolic pressures, the upper and the lower numbers that you get when you read your blood pressure. It may have an effect on what we call peripheral resistance. That is the resistance against which the heart has to work. And if that peripheral resistance is increased, then there's, of course, increased work that the heart has to do. So if you affect things that secondarily will affect the heart, you ultimately may affect the heart overall function, may predispose that heart to some aspects of failure, and make it even worse if the patient already has heart failure. But you can predispose the patient to things which can cause damage to the heart and, again, cause heart failure. The typical example that we both mentioned is high blood pressure or hypertension. So environmental factors may certainly secondarily affect the heart. It is not as though the noise may directly cause a heart attack, but indirectly. Now, the question of the noxious gas that we've been exposed to from the Canadian wildfires. Again, the same situation occurs that we stand in line behind Omar this time. If indeed the oxygen carrying capacity, the oxygen transfer capacity through the lungs to the blood that goes to the heart on the left side, if that is impaired, then the heart is receiving blood that has less quality of oxygenation. And therefore, there's less oxygen that the heart can pump to peripheral areas, the tissues, etc., where it's needed. So if we are, in fact, not able to get blood which is appropriately oxygenated, we will pump blood that's not appropriately oxygenated through the heart. So these indirect ways may affect how, in heart failure or in other circumstances, we are putting out blood or we are suffering consequences of the environment and ultimately affecting the tissues that the heart has to pump to supply.
Very good. Dr. Court, I know you're just sitting back down, but
No, I'm doing so. Doctor, you mentioned COPD that encompasses emphysema and bronchitis.
Mhm.
Is there an X-ray test and or a physical feature of the patient that can differentiate between the two of them? Say, for example, there's a chest X-ray in the emphysema looks different from the bronchitis or the body habitus. Is this a small person, so-called pink puffer and blue bloater?
Yeah.
Can we just use those as a starting point to be able to identify these patients?
Yeah, we don't use those terms anymore, but pink puffer and blue bloater, but I understand what you mean. Yeah, there are definitely lab tests as well as X-ray and with pulmonary function tests, and as well as the way the patient looks. You'll notice that most patients with emphysema are thin, and most of them will be they will have what we call a barrel chest, meaning that when I talked about the fact that they can't exhale most of their lung volume, their chest always seems like it's full, like it's sitting up. And when they are significantly short of breath on minimal exertion, if they have a mild to severe, moderate to severe emphysema. As far as the chest X-ray is concerned, they have what we call hyperinflated lungs, meaning that on the chest X-ray, it looks like their lungs are very large. And usually their hearts are thinner because their whole thorax or body habitus in the upper part of their body is kind of stretched out, and their lungs are large, and their diaphragms are pushed down, and they have flat diaphragms on that chest X-ray. So that's the difference. That's what the emphysematous patient looks like, emphysema. As far as bronchitis, usually it's a heavier person. Usually, as far as the chest X-ray is concerned, it may look normal, or it may look as though there's scarring on the lung tissues throughout the lung. Because as I stated, bronchitis is an infection. Our lung tissues, it's a very delicate tissue. And every time there is an infection, be it severe bronchitis or pneumonia or anything that's a true insult to the lung tissue, as it heals with a scar. And over time, that scar we will be able to see that on the chest X-ray. And the volume that we can take in, as I stated before, is smaller because that scar does not stretch like the elastic in our normal lung tissue. We have elastic fibers that allow those alveoli to stretch out and accept more volume of air. Now, those alveoli can't stretch because they're scarred, and scars don't stretch, and the volume that we take in is smaller. So we may actually have scarred and smaller lungs on that chest X-ray. And as I stated, a lot of these patients are heavier. There are other problems that you can actually find. It's like when someone's morbidly obese, it's called obesity hypoventilation syndrome. And basically what that is the patient is so heavy that there are small muscles between our ribs and our cartilage that have to contract and allow the ribs to open up. And if those small muscles cannot contract and push the ribs apart because of the body habitus and the weight on the lungs and the thoracic cage itself, then what happens is that you take in very small volumes, but you aren't able to exhale the CO2 or our waste products sufficiently either. So it's obesity hypoventilation syndrome. And those patients have significant decrease in oxygen being delivered to the body, as well as inability to get rid of the CO2 or the carbon dioxide that we're supposed to exhale every time we breathe. Okay, hopefully I answered your question.
Yes, you did.
All right.
So should I hop in now and discuss some of the mental health impacts of chronic disease?
That's where we're going. That's where we're going. But before you do that, I'd like to introduce the doctors that joined us. Dr. Simon, can you introduce yourself, please? Can you turn, you're on mute.
Hi, my name is Dr. Simon Segun. I don't know if you can hear me.
Yes, we can.
Okay, I'm a nephrology, a kidney specialist. I practice out of Beth Israel in Newark, the Cooperman Barnabas Center in Livingston, and Clara Mass Medical Center in Belleville, all here in New Jersey. I'm glad to be here. Thank you.
All righty, thank you. Dr. Patrick Anderson.
Hi, everyone. Another wonderful Saturday afternoon. Honored to be here with this illustrious group. I'm Patrick Anderson. I'm a board certified gynecologic oncologist, and I work in the RWJ Barnabas system with these astute, illustrious, and honorable gentlemen. Glad to be here.
Thank you, Patrick. And Dr. Nelson Aluya, you're on mute, Nelson.
Yes, good afternoon, everybody. Greetings to everyone, wherever you are. My name is Nelson Aluya, medicine and pediatrics trained, currently Chief Medical Officer of NCAC, which is the Newark Community Health Centers. It's a pleasure to be here once again.
All right.
Thank you.
All right, Dr. Salam, you're up.
All right, so just to discuss some of the mental health impacts of chronic disease. And I know the focus earlier in the conversation was pulmonary disease. So an example of a chronic pulmonary disease might be asthma, or we could think about hypertension, diabetes. We have Dr. Simon Sagun here, and his focus is nephrology. So end-stage renal disease, all of those could be chronic diseases. And I know Dr. Atherley probably deals with his fair share of congestive heart failure. So typically when someone has a chronic disease that's associated with organ damage, there's a loss of function. So whenever you have a loss of function, someone is functioning at an ideal level, and now they're at a point where they can't do things that they were once able to do when they were healthy, there's a grief and mourning period. And so you could go through stages of grief, right? So whether it be denial, and this is the person with congestive heart failure, they're in denial of that heart failure. So at the next snowstorm, they're outside shoveling, and they could really put themselves at significant risk. You could be very angry as part of the stages of grief, which do not occur in a particular order, and they could occur simultaneously. So anger in terms of there's frustration, you lose control, you're no longer functioning at the level you could in the past. And then there's bargaining. Why me? Why did this happen to me? Or there's a sense of guilt that this is some curse from a prior transgression. And finally, if you're able to work through these stages and get to acceptance. So you have a chronic illness and you have to figure out psychologically, is this something that's going to dominate and control my life and ultimately end my life? Or with the amount of life I have left, how do I learn how to live at peace with this disorder? And remember, prior to having this disorder, you were a human being with relationships, with interests, with significant elements to your identity beyond the disease. So you're much more than just being someone with end-stage renal disease or COPD or diabetes. So it's important to think in terms of what I enjoyed doing during the pre-morbid phase before I had this chronic disease, and what am I able to continue doing? So it's important to maintain interest within your abilities. So if you were once a reader or a track athlete, perhaps you can't run the way you used to, but maybe you could walk, right? The other thing too is it's important to find community. So no one wants to suffer alone. Our brains are designed for us to be very social creatures. So we want to find community. Also, it prevents you from having to reinvent the wheel. So it's important to find a community of individuals who may share your medical condition, but they're thriving. And then you could find out, you could trade tips in terms of how you could manage your lifestyle, whether it be dietary changes, changes in physical activity, all in the service of learning how to live with this condition versus having the chronic disease dominate your life and essentially send you to an early grave. Finally, there are increased rates of depression and anxiety associated with chronic disease. And so if someone is experiencing a chronic disease, they're linked to very competent and capable providers like brothers on this call. But despite the successful medical management of their chronic disease, they have flagging energy and concentration, loss of interest in things they used to enjoy, those are more consistent with signs and symptoms of depression, and it may be time for them to get help. Or if folks begin to report passive suicidal thoughts, I wish I could go to sleep and not wake up. I wish I didn't have to be here. It's very, very important for those folks to get help. And it's critically important for non-mental health professionals, like most of the brothers on this Zoom, to screen these patients for depression and anxiety. And anxiety, typically chronic disease, is associated with uncertainty. And so when are things going to get to a point where I'm bedbound or I'm really tethered to where I live? And there could be a sense of hopelessness and uncertainty and excessive worry, and that's the anxiety. And if it impairs your ability to function or to derive joy from living, that's when it's time to involve a mental health professional like myself or a psychologist for various forms of treatment, whether it be therapy, talk therapy, counseling, or medication management, or a combination of the two.
Excellent, excellent. Dr. Anderson, you have your hand up first.
Yes, this is for Dr. Salam. This has always been an interesting conundrum for me. How do you reconcile or evaluate a patient who's had a significant stroke, where we tend to focus on the physical deficit, but as you well know, there is also a psychological component, which, because often of the physical deficit, because of the type of stroke, because of the ability to express or not express thoughts and feelings, what do you do with those patients who have these strokes that we know are chronic issues?
Well, you could look at this in a few ways. Now, strokes are one of the medical phenomena that could be very debilitating. It largely depends on the real estate in the brain that's affected. So let's say a language center is affected, or parts of the brain are affected that impair speech or cognition. That could be really problematic. But if those parts of the brain have been spared, so your cognition is intact, your ability to communicate is intact, then those are folks who might benefit from therapy. You really want to keep an eye on the level of functioning and the level of if someone is becoming hopeless over time and they're becoming consumed by negative thoughts and this profound sense of hopelessness, and where they're beginning to withdraw from life over time, right? And so you may notice it in your very fastidious patient who, or relative of a patient of yours who always accompanied them to the appointments. Now they're not showing up anymore, right? And these folks who are withdrawing from life, it's really incumbent upon professionals to inquire, investigate, ask, and see what's going on. But it can be really tricky to determine what is a function, what deficit is a function of the stroke, a neurologic problem, versus a psychiatric or a psychological issue. But as you well know, strokes, particularly that affect the prefrontal cortex, put you at much higher risk of comorbid depressive episodes.
Excellent, excellent. Dr. Corey?
Dr. Salam.
Yes.
But very frequently, I come across a patient who may have felt that whatever is happening to them now may be as a result of either their transgressions in the past or something that their family did. How would you psychiatrically approach such a patient? How would you start treating them in terms of, we just need a little mini psychiatric session from you in terms of such a patient that you might see?
Well, the center of what we do as psychiatrists is rapport. So it sounds like you're discussing someone who has a very strongly held belief of their medical condition being a function of a previous transgression. If you're not familiar with the culture, you certainly don't want to challenge that, because that's an effective way to end the rapport, right? So you might want to obtain a cultural, you want to take a culturally competent approach. You want to make sure you're validating their feelings and their beliefs, but you also want to focus like a laser on their functioning over time. And it may involve obtaining collateral information from relatives or medical or advocates in their lives. And you're an expert in your family member. Tell me about them. I know they feel overwhelmed by guilt due to some previous transgression, but how are they going about life? How are they going about their activities of daily living? Are they holed up in their room with the shades drawn? Has their ability to care for self dropped off? And if you answer those questions in the affirmative, you don't try to hope, wish, or pray away what your eyes see. And you really recruit the family member to encourage, the trusted family member to encourage the person to get help.
Very good.
All right. Excellent, excellent. That was an excellent question. Also, Dr. Court, one that, boy, I have several questions here that let me approach some of those before we take our break. And then after our break, what we're going to do is, Dr. Simon, yeah, do you have a question?
Yes, sir. So I guess your previous answer may, in a way, pertain to this question I'm about to ask. Every now and then, I have patients who have a very deep belief in some other substances, voodoo, alternative powers, and I see them and they have kidney failure, for instance, but they believe they visited an aunt or an uncle's home and they drank some stuff a month or two before, and they just hold this very strong belief that somehow that's responsible for their symptoms. But I've also seen people who have traveled to Africa and then they believe they ate some other things and then they're back complaining of this non-stop abdominal pain. And we do series of tests, CAT scans, and whatever you have, and everything is negative. But they have this strong thinking there's something wrong. Now, they're not clearly psychotic to me. Well, I'm not a psychiatrist, so I can't use that. But they have this strong belief and they have this symptom. And how do you approach people like this? And do you suggest we send them to see a psychiatrist? Thank you.
So what we're trained to do as psychiatrists is the things that could do the most harm to you the most quickly are the non-psychiatric concerns. So you certainly want to rule out any medical reason for the symptoms, right? So if you have confidence in the workup and that you've ruled out all possibilities, then what you could do is you could frame it in a way that perhaps sometimes folks could be so overwhelmed with the stress caused by the symptom that it may be helpful for them to talk to someone about this. Now, what you're describing, it sounds very similar to almost like a conversion phenomena. And so I like to define terms. So sometimes in the face of overwhelming stress, you metabolize that stress through physical symptoms. And sometimes it could take on very dramatic forms. So let's say, this is a really dramatic example, but let's say a husband comes home and he finds his wife in bed with another man, and he could be so struck that he believes he's blind. So that's a dramatic example of a conversion phenomenon. So you may want to explore, a skilled mental health professional would explore other areas of that person's life for sources of stress and try to connect with them on that level. But if you have faith in the workup and you feel that they are medically in the clear, you could always invite folks to have a conversation with them about anything that is causing them stress. And there are some folks, and for example, to tie this into chronic disease, there are many young people who suffer from asthma, right? And some of the, well, I don't want to go too far afield, but a young person who struggle with asthma or diabetes, whenever they get stressed, right, they may start wheezing and the family comes to their rescue, but the functioning of the family essentially shuts down. And then if this pattern is repeated over and over again, it's essentially they use their disorder to, whenever they're faced with a stressful situation, the attention shifts from the source of the external stress to the disorder, and they're granted some relief. That young person, now they're an adult, they've been doing that their whole lives. They have to learn more adaptive ways to cope than having an asthma attack or blaming an imbalance in their blood sugar for any psychological distress. So you will have folks who struggle with diabetes who all of a sudden they may stop taking their insulin or their oral hypoglycemic. Their blood sugar gets very high. They have mental status changes or other symptoms consistent with diabetes. So folks with chronic diseases have to learn more appropriate ways to manage psychological stress. And this could be done through psychoeducation within the context of therapy.
Dr. Anderson, yeah, I see you have your hand up.
Yes, Dr. Salam, I'm beating up on you today. I apologize for joining a little late, and this may have been discussed in the section on the environmental, chronic environmental conditions. But what approach do you take for patients with chronic illness where the focus of the mental stress is now on the caregiver? How do you approach evaluating the caregiver?
Sure. So first, you have to assess the situation and what are the caregiving options. Sometimes the only option is the spouse, the adult child, but really what you have to do is focus on them and encourage them to engage in self-care. It's like what you hear on the airplane, right? So the person who's under their care is only going to do as well as the caregiver is doing, right? The young child that's traveling on the airplane with the parent, they're only going to survive if you lose cabin pressure. You put the mask on yourself first so that you remain conscious and therefore you can help the dependent child. So they have to be given permission to care for themselves, right? And oftentimes that will require a break. Now, there's some caregivers who that becomes a part of their identity and they don't see any alternatives for any other caregiving alternatives, but they may not have necessarily explored any options. Again, the advantage of finding a community centered around this particular disorder, whether it be respite interventions, whether it be close friends and relatives who you're not calling on all the time, but who are giving you a break. Caregiving could be very demanding and it could be very thankless. And you could harbor tremendous feelings of guilt because this is my mom or my dad who took, or grandma, nana, who took care of me when I had great dependency needs. And I'm very frustrated because I'm overwhelmed with these caregiving responsibilities. But caregivers have to be encouraged and given permission to take care of themselves. And again, to explore alternatives where they actually get a break, get time away from those responsibilities. I think all the brothers here would agree that taking vacations and time off makes us better doctors. I know it does for me.
Excellent, excellent. Thank you, Dr. Salam. Dr. Salam, anytime you come on, you're going to be a
It's all
highlight.
good.
Dr. Aluya, please.
Thank you so much, Dr. Salam. I mean, you have just laid it out so completely well. And I wish, there'll be some curriculum that's set aside for, it's called teaching the teacher or something like that. A curriculum where we'll teach those in other specialty about the elemental components of psychiatry and how to handle these issues, because it's really big. And as the population increases, the diversity increases, and all of these things begin to increase, we need the representation, at that table where we also have access to healthcare, not just physical health, but mental health. And that is becoming really huge. And it has to be discussed, both at this level, meaning, at the providers level and those who are practicing, but more so at the school level, medical school, where this has to be in the curriculum on how to approach individuals who are mentally ill, ill kind of, but also a curriculum to address these mental health issues, even at grade school level as well. Just to break it down in the form of cartoons and all that. I see recently where Sesame Street pulled out a cartoon with Big Bird and Larry and all that, talking about, understanding yourself. It's okay to feel the way you feel and all that and all that. So it's huge. Psych is so big. I can't, just say so much about it. But the two things that you talked about was the conversion issue, which is a big one. Now, conversion is actually a step beyond somatization, where a whole lot more people somatize than usual, and they come to the office and they complain of certain things. If you don't pay attention to them, you think it's actually a disease state. But meanwhile, it's just an expression of an anxiety state. And that's why the primary aim is to sit, ask them some questions, and ask questions around them, so you truly understand what are the mitigating factors that lead to the issues where they somatize. And I'm sure you're going to talk, give us a better explanation of what somatization is. Now, there's an entity, I'm sure, which I'll ask. It's a psychogenic fugue that takes place. Could you explain psychogenic fugue and somatization as it relates to everything else as well? Thank you.
Wow. So psychogenic fugue is something that you often read about as a student or resident, but you rarely see. But so in a fugue state, someone could travel an extensive distance and they could basically show up in completely divorced from their day-to-day life. They could show up in another city, and they could appear very confused, as if they don't know how they actually arrived there. And so it's an extreme example, similar to conversion disorder, where a very intense psychological stressor is converted into a manifestation of a physical symptom or some type of bodily impairment, right? But a fugue state is, you're almost like, it's like a form of psychosis. You're temporarily divorced from your regular reality. So you show up in I won't use Vegas because there's so many forms of entertainment that draw people there, but like you show up in Tucson, you appear confused, and it doesn't make sense like how you actually arrive there, but it's like a combination of a physical divorcing yourself from the source of the stress, as well as psychological. So it's creating distance between the source of the stress and your psychological location, and sometimes your geographic location. Now, in terms of somatization, so that's like a milder form of conversion. So again, you manifest psychological stress or distressing psychological stimuli into a physical symptom. The most common ones being chest pain, shortness of breath, belly pain, back pain that doesn't go away. And one of the major problems with somatization is that providers are not aware of it. They may not take the report of the patient very seriously. And so when folks feel like they're not being heard and empathy is not being shared with them, it can be deeply, deeply frustrating, right? And folks could be very, very disappointed. And again, it could affect the rapport and their ability to come back to treatment. So it's, you achieve a lot by listening to a human being. Who doesn't want to be listened to during their suffering, right? And then the invitation to have a conversation about these distressing experiences that are manifesting as physical symptoms. I remember I was so impressed with a family practitioner who, when I was a medical student, I was shadowing them, and they diagnosed depression in an African-American woman who was in her 30s. She had at least 3 young children, and she came in with a number of vague somatic complaints. And the way this doctor put it together, they diagnosed this young woman with depression, and she had no one had viewed the case that way. And almost immediately, she felt acknowledged and a sense of relief that someone was able to recognize the pattern, put it together, and recommend treatment.
Excellent, excellent. Dr. Anderson, I hear you up there.
You know, I could be a student of Dr. Salam all day, all night. And it's amazing to me that you can take conditions, symptoms that are so inexact, that has no measurable parameters, and come to a final diagnosis/condition that can be addressed specifically. And I say this to say, I was going to ask Dr. Salam to give us an expanse as to dementia. We have one of our psychiatric colleague who, when I ask him to evaluate a patient, and he comes to me and he said, this person has dementia. And I'm saying to him, how can you say that? This is a high-powered lawyer. The reason we requested your presence is 2 weeks ago, in the presence of a family member, we discussed a specific condition, specifically what needs to be done. She agrees to have it done. And she comes today, seemingly completely oriented, remembers her profession, remembers her professional nickname based on how powerful she was, but completely says to me, we did not have that discussion. So now it becomes, and Kevin can attest to this, we ask a psychiatric evaluation for competence. Now, can she have competent decision making? He evaluates her and said, this is dementia. And for me, that totally eludes me. So in terms of dementia, how do you evaluate patients for dementia when we're speaking to such subtle changes in your thought process, such inexact issues that you kind of can't measure, but it's more like a feeling?
Now, let me first qualify. I have the advantage of being a child and adolescent psychiatrist, so I don't
asking easy questions today.
I'm not living in the dementia world. However,
I hope you never live in the dementia world.
But there are neuropsychiatric assessments where you could address dementia, and dementia typically has some very common causes, right? So the most common form of dementia would probably be Alzheimer's, and right after that would probably be vascular, right? So, if someone has no history of vascular disease and hypertension and TIAs and things of that nature, that drops on your list, right? And then many forms of Alzheimer's run in families. So if you take a family history spanning several generations, right, you may discover that, or you may discover risk factors for such. But if I'm dealing with, there's like the sliding scale of competency, okay? And so you have a high-powered professional who, you know, their income and their livelihood depends on their ability to work and their ability to navigate the professional world, right? You really want to be certain before you kind of plant your flag. So, right, you want a solid workup that may involve imaging, that may involve MRI, that may have involved neuropsychiatric assessments. I'm not sure I would completely rely on a clinical diagnosis with a mental status exam. And also with some forms of dementia, there are some biological markers, right? And all these things cluster together to increase the likelihood of that diagnosis. So I would, and you want to explore different realms of the person's life, you know? So in this particular scenario, and Patrick, I know you are a surgical oncologist, a gynecologic oncologist. Is there any chance that this high functioning person is in frank denial of their cancer diagnosis?
Listen, and that's for you guys to figure out. I always struggle whether this is actually a neurologic issue or a psychiatric issue. You know, maybe I'm the one who has the issue with trying to figure out, am I psychotic or I have a neurologic issue? Because sometimes it's really difficult for me to delineate, you know, what's actually happening.
Yeah, I mean that, you know, I would be very hard pressed to diagnose someone with dementia if that's the only, if that's the chief complaint or the problem that brought them in. They have zero memory of this discussion you had of a very serious medical condition. But in all other avenues of their life, they're functioning at a high level. There's a chance it could be denial.
Mm-hmm.
Right? So I would caution folks before we plant the flag on dementia, especially in the absence of additional risk factors.
Excellent, excellent. Dr. Nelson, Aluya, I'm going to get to you, and I know you, and Dr. Salam, you're not going anywhere. I know you said only an hour, but
I know I will have to go, unfortunately.
All right, but hold on just a little bit longer.
Actually, to join a group of Black doctors in the Philadelphia area.
Oh, all righty. Well, hold on just a little. What I want to do, because we're moving on, and time is going, I want to reintroduce everybody real quick, and just get, because we passed through our second introduction. Dr. Aluya, please introduce yourself. We're going to do this real quickly.
Right. My name is Nelson Aluya, Chief Medical Officer at the Newark Community Health Centers. It's a pleasure to be here once again, and thank you for the incredible work that you all do wherever you do to uphold our community. Thank you.
All right, Dr. Atherley.
My name is Trevor Atherley. I'm an interventional cardiologist and predominantly based at Newark Beth Israel Medical Center.
All righty, Dr. Court.
James Court, internist, East Orange, New Jersey.
All right, Dr. Salam.
Dr. Kareem Salam, board certified adult and child and adolescent psychiatrist. I practice in Philadelphia.
All righty, Dr. Simon.
Hi, Segun Simon, board certified kidney specialist in North New Jersey. Thank you.
Right. Excellent. Dr. Clark.
Dr. Kevin Clark, surgical oncologist. I work at Newark Beth Israel.
All right, and Dr. Anderson.
Yeah, Patrick Anderson, I'm a GYN oncologist, work primarily out of Newark Beth Israel Medical Center.
All righty, and for once, I'm not going to forget myself. I'm Dr. Omar Bey, pulmonary critical care, subspecialty in nutrition. All righty, Dr. Aluya, you're gonna get your chance, and then I'm going to answer a few questions. Okay, Dr. Aluya, you're next.
Right. So I just wanted to chime in a little bit on the issue of dementia. Just like Dr. Salam was saying, I mean, in the primary care or medical field, we see dementia pretty early enough and often enough as well. And the unfortunate thing is that the incidence of dementia has drastically increased within the last 10 years. And particularly in our community, Black and brown community, and the Black community, huge. Now, the question is why? There's a percentage increase, I can't remember. But then the question is why? Is it the population is increasing? Is it increased stress? But we'll begin to see a whole conundrum, an association with diabetes as well. As the population, the incidence of diabetes increases, we begin to see the incidence of dementia increasing. And that rapid rate has drastically over 50% increase in the Black and brown community. So, but with that comes also the inflammation that comes with diabetes and everything else. Now, there are different types, vascular, Alzheimer's, Pick's dementia, and all those ones that we tend to have. But then we begin to see dementia in younger and younger age group, which is sad. And of course, there's a strong family history as well. So there's a big study coming out of Rutgers University trying to analyze the root cause of dementia in our community. And for those who are interested, Rutgers University, Newark, New Jersey, look it up and see if you can be part of that research study, because we do need the total number of Black participation in that study. It's important that we also take cognizance of this, because and the early intervention or recognition of it, because just like Dr. Anderson has said earlier on, one of the things that help mask dementia is the level of education that you have. And there's a word called confabulation, in the sense where individuals who have read so much and read a lot and done those, square things that they do, as the neurological concept begin to deteriorate, they find new pathways where they forget words. For instance, instead of saying it is very important, they can tell you it's imperative that. You understand? Because the word important they've forgotten, but then they use the word imperative. So they confabulate using those words. And the very early signs and symptoms that begin to show when you find out individuals with dementia, it can be really devastating in the community, to the family and the caregivers, to the point where it's the diagnosis is almost like that of cancer or worse even. And to see your family slowly deteriorate to the point where they don't recognize the children, they don't recognize family members, it's so painful. And then there's what they call the inevitable outcome. And people often say that the diagnosis from when diagnosis of dementia is made to, on the average, to death, usually takes about 8 years. So it's not something we should take lightly in our community, as we begin to share the word, to spread the word, so that we begin to pay attention to this.
Excellent, excellent. Dr. Simon, yes, you have your hand up.
Yes, just a real quick comment. I don't know if Dr. Salam is still on. I always thought you couldn't make a diagnosis of dementia on just a one-time mental state examination. I thought it was always something you needed time to evaluate the patient over a period of time to see a gradual pattern of memory impairment before you come to that diagnosis. Please correct me if I'm wrong. Thank you.
Yeah, it takes time to really do that. I'm not sure if you're still on, but once you see somebody who family members begin to complain that they're forgetting certain things. Now, the first thing you really assess is, how old is this person? Is this a 15-year-old versus a 25, a 35, 40, 50, or a 70-year-old? Now, there's a process called normal aging. In the normal aging, when you see somebody who, if it's somebody really old of a certain age, you can do a mini-mental assessment of that individual. Now, the mini-mental assessment is what you do to assess the level of multiple levels of cognitive function. And the total number is usually 30, And any number above 26 is normal. Now, 26 of less, then you begin to wonder. That you can do in your office, very easy. Now, once you see that, okay, you can confirm that this individual really does have memory issues. Then the next step is why? And then that's where the age and the pre-morbid state and everything else, medication, and even psychosocial issues on the background of that individual. You need to really dive deep into that. And then, of course, you do your blood work. Before that, serious detailed history. Has the person traveled before? Did they go to a place where they swam in the water, fresh water, and there's some amoeba in the brain, something like that? Or is there some new virus that took place? Did they eat raw meat or something? Crucel Jacob or something like that. So detailed history you have to truly take. And then the next step, you do the blood work, diabetes level and all that, and all kidney function to make sure that they're not on end-stage kidney disease. And ammonia is the reason why this is happening. And there's no liver disease and all that. And then, of course, you do the MRI, where you take a typical look at the brain and see if there are any issues. Is there a stroke? Is it a new or old stroke? Is there signs of infection or signs of a space-occupying lesion in the brain? So all of those things, yes, they do take time before you truly come up with the diagnosis of dementia. It's not a one-time, on the spot diagnosis, but of course, you can really tell if there's memory issues already. Then you can classify mild, moderate, and severe. And those stages connotes to a huge outcome to the individual and to the family itself.
Excellent review. Dr. Anderson, go ahead.
Oh, while Dr. Aluya has the platform, it would seem to me one of the things we as providers like is the ability to screen and evaluate ahead of time and look at progression, because I think that has a direct impact on the outcome as to how we develop diagnosis and treat these patients. Even in situations where the condition is incurable, the management is improved, right? So given the fact that we're so now on a digital platform with electronic medical record, is there a tool that we can implement in our medical EMR that allows us to evaluate a patient over time, develop a score? Because yes, you may evaluate someone for kidney disease and diabetes, but you can have severe diabetes, but has wonderful mental function, right? It's an association, not a direct cause per se. And even if it is, it's a gradual impact. So is there a tool that we can implement that allows us to, over time, see what happens to patients neurologically or mentally?
Matter of fact, there's a new, it's not you can call it a tool, but it's a machine where you can actually, it's a cap, you wear it, and it takes about 3 hours to really do those stuff. They give you certain things, they check your eyes, they check all of those, send some waves into the brain and all that. And then they come up with an expressive analysis of all of those things, over 50 of them, and they give you a score of what it is. I've forgotten the name of the machine, but some doctors do have them, and it can predict very early stages of Alzheimer's in any individual. So, ask your doctor if they have that, and you can look it up. I'll look it up next time. I'll tell everybody what that machine looks like.
Alrighty. Okay. What I'm going to do at this particular point, let me get to some of the questions. Number one question, and if a person has been misdiagnosed with asthma and given medications, treatment for it, can this cause more harm than good? And I guess this kind of is plopped in my lap here. We had talked about asthma earlier, and the treatment of asthma, most of the treatment of asthma at this particular point, especially mild asthma, mild to moderate asthma, when you're not in the emergency room, or if you're not having a severe bronchospasm, is inhaled asthma treatments, meaning the puffers or the inhalation of a mist or inhalation of a powder. And the greatest thing about this inhalation method is that even though one of the medications that we always worry about is called a steroid. And a steroid, what does a steroid do? A steroid it decreases the inflammatory component of the airway, and it decreases the mucus production, and it also helps as far as decreasing some of the spasm of the airway and the irritation of the airway. So it's one of the medications that we use quite often as far as asthma is concerned. Actually, it's one, and with research, it's one of the primary medications that we use for mild to moderate asthma. To tell you the truth, what I like about inhalation therapy is that very small amounts actually gets into the bloodstream. And that way, it's the amount of side effects that potentially occurred in the past, we don't really see those side effects as much. Now, to say that they never happened, yes, you can still have bone deterioration. Yes, you can still have increased infection secondary to the steroids. You can still have like the fungal overgrowing in your back of your throat, that kind of stuff. But it's less than it was in the past. Where we really find the problem is when you take a medication that's absorbed through the stomach. Because if you're taking a medication like prednisone, or if you're admitted to the hospital and you have to take IV steroids, that medication goes to every cell of your body. And true, there are a lot of side effects that can occur with those, especially if you're on prednisone, and it's a long treatment of prednisone, many months, many years of treatment. You can have significant side effects like high blood sugar, thinning of the bones. You can have changes in your eyes. There are many things that can occur secondary to prednisone, especially weight gain and diabetes. Those all things that can occur. So, and much more. So yes, there are certain medications. If certain medications, yes, if you take secondary to that would be the treatment for asthma that could cause permanent harm, and that is true. Hopefully, if you were not if you do not truly have truly have asthma, and the diagnosis is not that, then you were not exposed to these long-term treatments. All righty. Second question: how does our diet, from a cultural perspective, have an effect on our pulmonary system? So I guess I opened up pulmonary Pandora's box. You know, from a cultural perspective, our culture understand that we eat a lot of, rice, we eat a lot of potatoes, we eat a lot of pasta, fried foods. It seems as though fast food is a fan, especially for our young, and so being overweight is a problem, especially in the African American community. Understand almost 75% of African American females are considered either overweight or obese. And when you start looking at those type of numbers, we understand the medical problems that can develop secondary to that. So, and what we eat, how much we eat, psychologically, why we eat it, all is a problem from a cultural standpoint. Understand that if you're talking about pulmonary problems now, we're talking about things like dairy. Dairy is always something that causes increased mucus production in our airways. So if you're an asthmatic or have bronchitis or any respiratory problem, if you eat a lot of dairy, that could exacerbate your respiratory problem or respiratory condition. So, and also you think of things like allergies, try to control your allergies, or if you feel you have an allergy, go to an allergist and try to determine what type of allergies you have, what is your stimulus, and see if you can keep it under control, that's for sure. As far as weight is concerned, and people of increased weight definitely have increased chance of pulmonary problems. So those are some of the things that we can consider as far as pulmonary culture, as far as what we eat. Going on to the third one, and unfortunately, Dr. Salam is not here and is talking about, thank you, Dr. Salam, for your explanation. DA, what is that? BDA associated with newly diagnosed chronic disease. It's a little over my head. I'm not a psychiatrist, and I don't know if any of our primary care docs can help us with that question. If not, we will have to address this question the next time Dr. Salam comes on. And I'm sorry about that.
I make no illusions of being able to answer a detailed psychiatric question, but I see there are several components to the questions that have been asked. The one question that struck me, the one about the misdiagnosis of asthma, not only relates to sins of commission, but sins of omission. By that I mean that not only if you mistreat the patient for asthma, but if you make the wrong diagnosis and fail to diagnose something which requires treatment, a totally different treatment. So if the misdiagnosis, as was questioned by the member of the audience, of bronchial asthma, you may miss the opportunity to appropriately treat other diseases. And of course, the one in my field would be congestive heart failure. If the patient presents predominantly with shortness of breath, and for whatever reason, whether there's transient wheezing, or for whatever reason, the diagnosis of asthma is given, one has to be careful about not making the wrong diagnosis in that patient and failing to treat another cause of shortness of breath. Obviously, something like congestive heart failure, which can be diagnosed clinically with their number of tests that one would order to try to distinguish whether the shortness of breath is merely because of a pulmonary problem or it's because of a heart problem. And one of the commoner ones that we might use, of course, we do electrocardiograms, etc. But one of the commoner ones that we might use to assess heart function is an echocardiogram. This is an ultrasound of the heart. The ultrasound allows us to define several aspects of the structure. We look at the 4 chambers of the heart, but we also look at the valves. So valve malfunction could be missed. And this would be helpful in helping us to diagnose that on top of our using our clinical parameters. So depending on the age at which this patient presents with asthma, one has to consider the likelihood of other diseases which might be paramount and which would be important to diagnose and treat rather than just misdiagnose as asthma and fail or miss the opportunity to appropriately treat.
Yeah, excellent, excellent. You know, what
Probably,
go ahead.
that's probably the most important thing, one of the most important things in medicine, right? Is to make sure that your diagnosis and treatment are on the same line, because if you don't understand what the natural history is of both, right, you should follow a certain pathway if they're both on the same line. If not, either your diagnosis is incorrect or your treatment's incorrect, and failure to alter either one of those, will result in detriment or problems for the patient.
True. Yeah, I think most of us understand that the way, well, because of our ages, I know that we were trained this way. History, family history, and the history that the patient gives you and what they actually tell you they're experiencing, and the physical exam is so important. But that history that the patient gives you is so important that you got to stop and listen intently as to what problems they're having and how it's presenting, what they're feeling. It means so much as far as helping you come to an appropriate diagnosis, and that's so important. And and I just to add on to that, I'm just thinking about as far as asthma. Asthma, so a lot of times I have a patient that comes into the office and it's not lower airway, meaning below the vocal cords, but it may be the vocal cords or above. And just a very simple, talking about history and presenting symptoms, just a very simple listen. If it's an expiratory wheeze, then it's more likely asthma. If it's an inspiratory wheeze, then it's more likely vocal cords are above. So just something just as simple as that, you can get an idea as to whether you're in the right ballpark as a physician and you're treating it appropriately. But yes, you're right on key, Kevin. As far as Dr. Clark, as far as do no harm and make sure that we're doing the right thing for our patients. Alrighty. Now, we were supposed to cover some and part 2 of kidney, but we sort of got off the track. But before Dr. Simon gets off, I'd love for him to go through some aspects that we did not cover last time. Number one, we didn't cover dialysis. and that's a big component of chronic kidney disease. I mean, chronic kidney disease, and I know that he had told us about that last time. But Dr. Simon, can you just give us an understanding of what is chronic kidney disease and who and why somebody would go, well, I should say, need dialysis? And this was some of the things that we needed to talk about as far as Dr. Salam as well. And I think he covered it well. I think chronic kidney disease is included in some of the topics that he covered earlier. But Dr. Simon, can you just give us an understanding? Because dialysis is a part of our community and we need to know more about it.
Thank you so much, Dr. Bay. Sorry, I came a little bit late, so we were not able to kickstart the kidney aspect early. But dialysis is a big issue. The last time we were here, we talked briefly about the kidneys, what they are, where they're located in the body, the functions, in terms of filtering the blood, keeping us clean and healthy, regulating blood pressure, making hormones like vitamin D and all of that. And we also talked about several disease states and some of the signs and symptoms, how to recognize kidney disease. And then we zeroed in on chronic kidney disease, which is gradual ongoing kidney damage that are most of the time irreversible. And we put them into stages, stage 1 through to 5, 1 being the earliest and 5 being the end stage kidney disease, at which point we will say the patient needs well, I will call it kidney replacement therapy. And now the kidney replacement therapy have basic 2 options. One is dialysis, and the second one is transplant. Now, for dialysis, there are 2 modalities. There is a hemodialysis, where a patient requires either a shunt in the arm or a catheter, typically somewhere in the lower neck, upper chest area, and it has a port with 2 openings. And a patient is connected to the dialysis machine through these 2 ports, and blood flows out of one of them through the machine, where there is a membrane, or what we call a dialyzer in the machine, that does the work of the kidney. It essentially filters the blood and takes out all the bad stuff that has accumulated in the blood because the kidney is not working. And now the clean blood then returns to the patient through the other port. And this process is continued for about 3 to 4 hours, depending on the size of the patient. And after this is done about 3 times a week, in order to keep the patient alive and well until hopefully they get a kidney transplant if they are young enough for it. The other option is the peritoneal dialysis, which we're not going to talk about today. But instead of connecting you to a machine, we use your belly. There's a little thin membrane under the skin that covers the organs. We call it the peritoneum. It has the ability to also filter, just like the kidney. So we infuse some special solution into the belly, and your belly membrane, that's the peritoneum, does the filtration. And after the fluid stays in there for a few hours, we let it out, and then you get rid of the toxins. Dialysis is huge. In the US, we have close to 800,000 people on dialysis, or that have end-stage kidney disease. And that's about 1 in 4,100 people. It's not the 9th leading cause of death in the country. It comes with a lot of morbidity. It alters people's life, and not just the patient, but also the family members and the caregiver. You can understand having to take someone to go to a facility, sit there for 4 hours to get their blood clean, and then come back home. It can be draining, can be tough on the body. Most of the time, people are not able to stay employed, or it affects their social life. So there is a whole lot going on when people need dialysis. It's also more common among people of African descent, like we talked about the last time, because we do carry some genes. The ApoL1 gene we talked about briefly, that makes kidney damage more likely in Black people, almost 20 times more than people who don't have that gene. So dialysis has also come a long way. I'm just trying to rush through, give a quick overview, because when people hear the word dialysis, some people think it's a death sentence. And a lot of people are scared of it. Either they've had family members or they've seen people who are doing it. And so when they hear the word, most people do not like it. Dialysis is not that old, actually. In the United States, it started about 61 years ago. So in the 60s. So it's not that far back. And but a lot of progress have been made. When dialysis first started, it wasn't available to everyone. Like, I will give you a few numbers. For you to have dialysis in the 60s, you have to be a white male, less than 45 years of age. You have to be considered economic and socially stable. You have to be married with children, or a Protestant. If you had low socioeconomic status, if you were non-white, if you were single or non-Protestant, you couldn't have dialysis, even when you are at end-stage kidney disease. And by the way, before then, if you had end-stage kidney disease, the doctors would typically call you and your family, make your wishes, do your will, because the end was inevitable. So dialysis was a game changer in the 60s. It wasn't widely available, but now, through some progress, a lot of things have changed. It's now available. Still not quite where it needs to be, but a lot of progress have been made. So this is a brief overview about dialysis. There is still a lot more that could be done. The membranes have changed. When it first started, one of the professors that taught me, who was a fellow then with the first doctor that performed dialysis in New Jersey, Dr. Ribbo, back in the days. I don't know if Dr. Obey will be aware, because you've been around longer than I have. And they used to make these solutions in their backyard with baking soda and stuff, and they would bring it to the hospital to try to save people who were dying from kidney disease. But through technology now, we have filters that have been made that are more compatible with the human system. There's less reaction, and we're able to perform this procedure much more effectively and in a safer way. It is not as bad as it used to be. If you comply with your doctors and you follow the rules, there's a lot of dietary changes that needs to be made when your kidneys are not working, some medications that you need to take to assist your body. So if you do all that, I have a lot of patients on hemodialysis that are gainfully employed, that are working, that are still going to school and being very productive. If you follow along with your doctor, you're able to still lead a productive life, despite having to be on dialysis.
Excellent. You know, what I'd like to see if you could just talk about a little bit is transplant. The ability to transplant a kidney into another person, and what that entails, number one, for the recipient as well as for the donor. And then I'd like Dr. Clark to kind of give us an understanding of what how a transplant is done, and with the life expectancy, how that life expectancy changes at post-transplant and going from dialysis to a functioning kidney. Dr. Simon?
So, thank you. With kidney replacement therapy, kidney transplant is a better way to go rather than dialysis. It is a major surgery, and because of that, it's not everyone who has end-stage kidney disease that are suitable to have transplant. To be a recipient, you have to be healthy enough to be able to undergo the surgery. So there are screening tests that are typically carried out. First, they see how your overall functional status is. They check to make sure you're in good, you have good heart health. So we send you to a cardiologist to screen. We have to make sure you're up to date with all your preventable cancer screening. So your mammograms and your pap smears and your colonoscopies and prostate for male. And because kidney disease is a disease of the elderly, so we do expect some of these issues. So we screen for all those. And if you're if you've typically passed through all that and you're below 65, which is what most centers approve of, there are a few centers here and there that will take people older than that if you're in a very good healthy state, and then you're considered suitable for a transplant. Dialysis, the mortality, the risk of dying on dialysis is about 30 times higher for the same age of a patient who is not on dialysis. So you can understand why, although it does represent a significant improvement from before, because you were dying anyway, but we still know that it is not the optimal. Transplant offers you a significant amount of survival benefit than dialysis if you were a candidate. So we try to push for transplant for those who are eligible. Now, there are two forms of kidney transplantation. It could either come from a cadaveric donor, that is someone who has passed away, but their organs are still in good shape and we can use it to give someone who is alive but in need of one. We also do living donation. God has been so gracious to us to give us two kidneys, and we typically don't need both of them to be alive and well, especially if you live a healthy life. So we have people who are able to give up one of their kidneys to loved ones, to friends, and we have altruistic donor who just decides, hey, I just want to bless humanity. I'm donating my organ, one of it, to whoever may be in need of it. So all those type of transplantations are done. If you're able to go through the surgery, there are medications you have to take to prevent what we call rejection, because the kidney was not originally yours and your body will typically try to fight it because it will be seen as a foreign object in the body. So there are this medication regimen that we typically give people after a kidney transplant to allow the body let the kidney stay and function. When a kidney transplant is successful, it's a beautiful thing. It gives you a chance to return to normal life. You don't have to go to centers and be dialyzed, and you can return to your productive life, as it were. I will let Dr. Clark talk about the post-transplant issues or the surgery itself, because I do not perform those.
You did such a good job, Simon. I don't know. Right. So I think as with any other surgery, you have to be an appropriate candidate. And in assessing that, as you mentioned, your overall status to undergo an operation has to be assessed. The workup, which is a little bit different for other indications, for all transplant patients, is to make sure that you don't have an underlying malignancy. And that's something that we get involved with as oncologists, because if you do have a cancer that would not, it may delay your qualifications. And the reason being that with transplants, you have to be on immunosuppressive agents. If you have a cancer that is, and you put on immunosuppressive agents, that's going to make it worse, and that's going to be problematic. The actual surgery itself, so as opposed to other areas where we have to remove the existing organs, so liver transplant, you take the old organ in, you put the new one in. With heart and lung, you do the same thing. With kidney transplants, you leave the kidneys, the old kidneys in place, and you reconnect, or you put the new kidney in a different location and just attach it to the blood supply and to the bladder. It's, I don't want to say a fairly simple operation, but it's fairly technically straightforward operation in terms of accessing both the venous and an arterial supply, and then connecting the tube that goes from the kidney to the bladder. Again, most of the complications are going to be, they're technical complications related to the surgery, meaning the connections, every connection that you make, things have to heal. So all of the connections have to heal properly, which you can imagine in these patients, they have inherent problems with healing. And then the main issues with these transplants, two things. So the original disease process that caused the patient to get a transplant may still be around. So diabetes, hypertension, all of those things, you don't necessarily get rid of. And if there's any other illnesses, autoimmune diseases that previously caused, again, some of these things can still play a role in the transplanted kidney. And then there are issues related to being on lifelong immunosuppressive agents. There are complications just from the drugs itself, and then you can actually get secondary malignancies from being on immunosuppressive agents. So those are the main issues as far as the complications from the transplant.
Dr. Simon, question for you. In terms of eligibility, do patients go through the same protocol as they do in defining eligibility for dialysis? Because I would imagine the historical perspective as to who gets dialyzed probably has a parallel to that which you mentioned before, as to in the past who was eligible to start dialysis.
So you're referring to transplant and dialysis?
Correct, yes.
Okay, yeah, so the eligibilities are not the same. So for dialysis, there are what we call indications for dialysis. If you have stage 5 kidney disease, end stage, that is, irreversible, and you're sick from it, either you've accumulated so much toxins that your body is not able to get rid of, and now it's making your whole system sick, you're nauseous, you have no appetite, losing weight, that's an indication. If your level of acid in the blood is so high, so that's an indication. If you're retaining fluid, so when your kidneys stop working and you're not able to urinate, and now you're retaining fluid around your heart, your lungs, and everywhere in your body, that's an indication to have dialysis. Your blood pressure is seriously not under control, and you have end-stage kidney disease, those are the indications. And there is almost no age barrier when it comes to dialysis. I've had patients who are 93, 95, and they are relatively stable. They can have dialysis if they choose to, if they have those indications. But I've had some 70-something-year-old demented in a nursing home with pressure ulcers and have just very poor quality of life. and they may choose to say, hey, I don't want any more procedures done, I'm good, or the family decide we're not doing that. So by and large, when it comes to dialysis, the indications are mostly medical, like I have outlined, and anybody can have dialysis now today, unlike when it first started, once you have those indications. When it comes to transplant, the indications are a little bit different. Actually, not a little bit, a whole lot different. So first, you have end-stage kidney disease. So your kidneys are not coming back. Now you need a kidney replacement therapy, dialysis or transplant. Even if you're eligible for transplant, you may have to undergo dialysis first to get you cleaned up, to get you not so sick before you get the transplant. To be eligible for transplant, you have to be youngish. Most centers would take up to 65 years of age. And then you have to have no serious active malignancy going on. That's why we screen for all those cancers. If you have any history of cancer, depending on the type of cancer, you have to have a time lag, meaning the remission time. For instance, for colon, breast, you're talking 5 years, prostate, maybe a year or less. So depending on the type of cancer, what stage they were, how aggressive they were, you have to satisfy a certain number of years in remission before you become eligible. You also, if you have a donor, a willing living donor, it makes it faster for you because the average wait time to get a kidney transplant now is about 4 to 5 years nationwide. But if you have a willing donor, this can be arranged within months, 6 months, under a year. Also, the native disease that caused the kidney failure can influence your eligibility. If you've got, say, type 1 diabetes and your pancreas are totally gone, and that's what caused your kidney failure, you may not be eligible for only kidney transplant, because if we give you a new kidney, but your type 1 diabetes from lack of pancreatic tissue is still there, in no time, you're gonna, damage this new kidney as well. So we may be talking about simultaneous kidney and pancreas transplant. So your eligibility may be a little bit different. And if you've satisfied all this, then there is a system called the UNOS. This is a scoring system. And now that puts into consideration your age and how long you've had end-stage kidney disease, or how long you've been on dialysis. So your first day of dialysis, for instance, your geographic location, your sex, and all of that, and how sensitized you are as an individual. Sensitivity in terms of if you've had previous antibodies, because you're having a new organ coming into you. If you're already sensitized from previous events, if from maybe prior transplant, prior blood transfusion, for females, if you've had multiple children, because with every childbirth, you're exposed to another human DNA, so you can develop antibodies from those events. And they also measure your antibody levels. So for every of those factors, you get a score. And based on your scoring system, you're ranked on a list of eligible people. And then once a kidney becomes available, and this is in the case of cadaveric donors, those who are waiting on the list for, when a young person dies in a motorcycle accident or other forms of death, and their organs are still good and they've, indicated to be a donor. When a kidney becomes available in a particular area, let's say if you're listed in New Jersey, when a kidney becomes available in New Jersey, they run the test on this kidney, and then they compare it to the people on the list. based on the blood group, how sensitized you are, how long you've been on dialysis. If your score is higher and you're towards the top, then they see who is most matched with this available kidney, and then they call you in to let you know about the kidney. They'll give you the characteristics of the kidney and ask if you're willing to accept it or not. And that's basically how, in a nutshell, the process works. So the eligibilities are very, very different from just having to undergo dialysis. Now the kidney transplant process has also evolved over the years. Before, we were always looking for the best kidneys to transplant people. But now with advancement in technologies, there are what we call high-risk kidneys. So kidneys from, for instance, commercial sex workers or people who may have used intravenous drugs or people with hepatitis, certain infections that we know are curable now. It's just helped to increase the donor pool for people who are waiting for transplant. So we're trying to get as much people transplanted as possible because we know staying on dialysis decreases your survival and the length of life. So I don't know if I answer your questions, Dr. Anderson.
Yes, you did.
Yeah, that was excellent, excellent. You know, the thing of it is that we had some interesting topics today. Yeah, we talked about quite a few things: congestive heart failure, well, cardiomyopathy, and pulmonary edema. We talked about asthma, bronchitis, COPD, chronic kidney disease, transplant, dialysis. So this has been a great, great show. But unfortunately, like all things, it must come to an end. I enjoy this so much. I hate for them to come to an end, but it has to. I would like to state that we will be on vacation for August. So next month, we will not have a show. We're going on vacation and many of the doctors won't be around. So we're going to take that month off and we will see you in September. And I guarantee you, we will have an exciting topic for you. So in closing, I'd like to thank OBHealthy for allowing us to bring this webinar to you. Yes, and they let us use their platform, and we're so grateful for that. Understand that our webinar is every second Saturday at 1 o'clock, and please tell family and friends. It takes a village to educate our population, all people from Africa, of African descent, about their health and wellness. So thank you for participating today, and please, when you do participate, type in your questions. If you want to see any of our past webinars, just go to OBHealthy and click on our YouTube sign. It brings up all of our past webinars, a wealth of education as far as health is concerned for all of us. And thank you for going back. And please subscribe so we can continue to bring this webinar to you via YouTube. The most important thing that I can say, and I'm, you know, I take this seriously, it truly is the most important thing that I can say, is that please do not change any aspect of your medical care until you consult your physician. Only your personal doctor can truly take care of you from a medical standpoint. And I just look forward to seeing you in September. Remember, we will not be here in August. And until then, I'm going to say peace and enjoy your summer. Peace, everyone. Thanks to all the docs.